Hello, I want to welcome you to the 26th Wall Street Comes to Washington Healthcare Roundtable. I'm Paul Ginsburg, and I'll moderate the discussion today. The purpose of this event is to give the Washington health policy community insights into market developments that are relevant to policy through the eyes of equity analysts who advise investors about the likely performance of publicly traded healthcare companies. Along with a thorough understanding of healthcare markets and the companies they follow, all of our analysts closely follow public policy because of the implications for the companies they follow. Before we get started, I want to thank Arnold Ventures for supporting this event and recognizing the value of providing a forum for outside of the Beltway perspectives on healthcare. Our format will be a roundtable discussion based on questions that have been shared in advance with the panelists. We'll have two opportunities for audience question and answers, the first at around 2:45 and the second before we end at 3:30. You can either send questions via email to events@brookings.edu or via Twitter at #WallStreetHealthPolicy. We have staff monitoring email and Twitter to make sure that we get as many questions as possible. Also, please note that the analysts cannot answer questions about the outlook for specific companies. A transcript and webcast of the conference will be available through the Brookings website next week. I want to introduce the panelists. We have an excellent panel today. Two panelists, Ricky Goldwasser of Morgan Stanley and George Hill of Deutsche Bank, are veterans of previous Wall Street roundtables, while Ann Hines of Mizuho Americas is joining us for the first time. The COVID pandemic has profoundly disrupted American society and U.S. healthcare. Since January 2020, nearly 1 million people have died from COVID in the United States, and the evidence is incontrovertible that people of color have disproportionately borne both greater health harms and economic hardships during the pandemic, highlighting long-standing systemic inequities, especially in healthcare. At the same time, the pandemic has spurred innovation in healthcare delivery, particularly telehealth and remote patient monitoring and other digital applications. So going into the third year of COVID, cautiously optimistic as we move toward a more manageable new normal, what are the big questions learned and what are the impacts likely to be going forward? Now I'm going to start my questions with some on the pandemic. And the first one is, what's been the financial impact on various types of providers and health plans? Could you characterize the current financial standing of key provider and insurer types? And are there any long-term implications?
Ricky, should I jump in first? As we joked about before the panel. First, Paul, I say thank you for having us all here and having us all back. I'm going to give a very brief disclaimer, which I think probably applies to Ricky and Ann too, which is that the three of us all do investment research for investment banks. You can assume that the banks that we work for seek to do business with any individual companies that may be mentioned here, though I know I have no individual conflicts to report, and I can't imagine Ricky or Ann have any individual conflicts to report either, but I won't pretend to speak for them. I guess, as we go into year 3, and we're now rolling from what we hope is pandemic to endemic, the endemic phase of this, I think from our perspective, we're generally watching the insurers and various provider organizations as it relates to both what they've learned and the benefit from COVID. I do feel like this is a very wide open topic, which we could talk about for, we could probably spend an hour and a half on this. I would probably focus on my areas of coverage, which are managed care and the drug supply chain, where managed care largely has seen COVID as an opportunity, where they've collected revenue in the form of premiums and payments from plan sponsors and other beneficiaries. They've tended to see at the earlier stages of the pandemic a lot of volatility in utilization, a lot of volatility in medical costs. So medical costs were volatility to the downside, not necessarily volatility to the upside, where you saw earnings positively surprise, and then you started to see the rebound in utilization. I think one of the more interesting parts of the channel that we've watched is the pharmacy chains, the Walgreenses and the CVSs and the Rite Aids of the world, where they were getting pretty generous reimbursement for the administration of the vaccines. They had pretty high market shares in administration of the vaccine deliveries. Then you had the in-store testing and the at-home test sales, which are pretty significant economic contributors to those guys over the last 12 to 18 months. And then from a provider perspective, you saw generally, whether it's docs' offices or physicians or what I would call like the various flavors of the retail clinic model, saw demand for services fall and then start to rebound. But I think for most of healthcare, we've seen COVID be a positive financial experience, at least as of recent. And I think, a lot of the learnings have been around readiness and around supply chain and around the ability to deliver care in what is a volatile and uncertain environment. But like we could spend an hour and a half on this topic, but I want to be sure we keep moving, give Ricky and Ann time to opine.
So from my perspective, and Paul, thank you for having us with you again. It's always a pleasure to have that sort of discussion and dialogue. From our perspective, when we think about the financial standing of key providers in insurance, I think that large insurance and large provider groups have weathered the storm. And when I say weather the storm, I think earlier in the pandemic, there was this anticipation that the large insurers are going to see a windfall, right? Because just less core demand. And over the last couple of years, I think the market have realized, right, that was not the case, right? And there are kind of like a lot of things in play here. But overall, right, with all the puts and takes, we think that 2022 is going to be there are easier comparisons for them financially versus 2021. But really the question is like, what happens with the smaller players, with the regional players, where potential losses sort of impact their profits, impact their cash flow. And if you take that, right, and you combine it with the fact that we're in a really tight capital market right now. We're in a tight capital market, which is more difficult for smaller players to raise money. We are in a very tight labor market. And these are all things that we're going to talk about later, which means that the cost of business is increasing. And that's more of a burden for the smaller guys. I think that is, to me, sort of the broader question, right? So being well-funded at scale is even more important than pre-pandemic. And I think that we have to ask ourselves the question, does this mean that longer term there's actually less competition? And does this mean that we're going to see more M&A in the future?
Good
Hi.
point. Go ahead, Ann.
Yeah, maybe I'll just add from a provider perspective, especially hospitals, since I cover that sector. I would say the main takeaway, at first, there was a lot of uncertainty what would happen, but I think what came through was really the resilience of the American people, because even though there was a big blip in utilization, it really did come back stronger than people expected and faster than people expected. Obviously, it varies between which payer. Younger people, commercial insured people tended to come back faster than Medicare or Medicaid. Medicaid is still really not back to pre-pandemic levels. But there definitely was a resilience. And I think for me going forward, the biggest question is, like to what Ricky said, the cost of business will be increasing. And especially for providers, nursing, and we will address this later, nursing is a big factor. Like, has COVID structurally negatively impacted that industry? And I think it's too early to tell because we still have these COVID waves and dips. But once that settles out, we'll really figure out if it's structural or not.
And it's interesting what you said about Medicaid not coming back, because there's so many more Medicaid eligibles now.
Yeah.
That's really striking.
Yeah, I think that socio-demographic got hit hard with COVID, so they're probably less likely to get care at hospitals because they were afraid of COVID. Sure.
Thank you. So presumably what you've all talked about may have implications for consolidation. Is this likely to mean that we're going to see more consolidation, or is the financial stress of the smaller organizations going to be a barrier? And how will the more vigorous promises of antitrust enforcement play in here?
So we think that we're definitely going to see more consolidation, and in our 2022 outlook, that was one of the themes that we talked about. In I think that we're going to see small scale players sort of merging with others to create scale. We're going to see the larger stakeholders, whether they're healthcare companies or tech companies in some areas, or large consumer companies. We see them kind of like looking at healthcare, opportunistically looking at M&A. I think what would, and we haven't necessarily seen it yet at scale, but I do think that we're going to see more of it in the second half of the year, because the thing we're watching for is what's happening with those companies that need to go back and raise money next year, especially given all the volatility. They're just going to be, I think, more pressured to go ahead and do something that's strategic. I think it's going to depend on their boards, depends on the C-suite. I think they're still kind of like hanging in and hoping that the market is going to return and that multiples are going to go up. But I do think that is going to catalyze that kind of like step up in M&A.
Yeah, if I can dovetail on that, I think Ricky kind of hit on this very well in the first part of the last question. And now I think we all probably look pretty closely at the value-based care space, and you've seen multiples in that space kind of implode. A lot of the companies that have come public in the last year, whether they came public through the traditional method or through the SPAC method, which is a word we don't hear a lot. SPAC's a 4-letter word now. But like these are companies that are now trading below their last private round in some cases. So even the private investors are underwater. It's amazing how what's old is new again. I almost call this like WeWork 2.0, where these were companies that used to be rewarded for growth in their KPIs and their stock price, whether the growth was, membership, premiums, lives, however it was being characterized. And the goalposts got moved on these companies as the risk profile of the market moved and the risk profile of the market changed. And all of a sudden, we used to cover companies that had lofty multiples that were considered expensive stocks on the promise of earnings delivery in 2025 or 2026 that are now, I thought they were expensive stocks before based on the earnings profile in 2026. And now the market has heavily discounted their ability to deliver earnings in out years, and the stocks have kind of imploded and valuations have imploded. To Ricky's point, the need for capital is going to force them into making strategic decisions, either around raising capital at unattractive terms, or will they be pushed into the loving arms of the consolidators, as opposed to looking for that next round of capital. Whether it's the United Healths, the Anthems, the Aetnas, the Humanas that'll be out there with the waiting arms, or the large provider organizations. I think it remains to be seen, but and what's interesting is there are so many factors at play here. There's the changes in the capital markets, there's employment, there's wages, there's interest rates. There's like a lot of these decisions right now are driven as much by the macro as they're being driven by the micro. No.
Yeah.
I'll kick it over to Ann.
Yeah, and I would agree. And I think it really is sector specific as well. Like, for example, I cover the clinical lab sector. And if you talk to some of these smaller labs, if they weren't doing COVID testing, which is very elevated pricing right now, they might have to close or sell because the cost of their business has increased so much that a lot of these benefits that some healthcare service companies are getting through the public health emergency is probably masking some of really the trouble going on beneath the business.
Oh, that's really interesting. I want to switch now, because it was mentioned, to value-based payments. And my question is, are we seeing just more value-based payment contracting between private insurers and providers than we've seen before?
Maybe I'll start with that. I think maybe to a degree, but it's going to be slow. That's just how I view it. A lot of the companies are talking about it more as a big strategy, like United Healthcare, some of the managed care companies, especially with their Medicare Advantage population, really trying to shift people into, providers they own to, just to save costs and things like that. And again, I'm a believer in it. It's just more timing. I think it's very difficult to change the traditional fee fee for schedule. Hospital companies, they'll say we have some value-based contracts, but it's really still like 5%. So again, I think it's happening. I just think it's going to happen slower than some people think.
Yeah, it seems though this is a story that if you were here 4 or 5 years ago, you might have said that as well. And I just want to point out that, change has really been very slow. And, unless one of the other panelists thinks it sees something happening more rapidly, maybe that's the takeaway.
Well, I guess I would put just a slightly different spin on it. I wouldn't say that I necessarily see it differently from Anne. I think Anne is very, very right on what you're seeing on the hospital side. I think on the outpatient side and on the ambulatory side, you're seeing things move much faster. We've seen a tremendous amount of capital formation in that segment of the market over the last 2 to 3 years. This is where, I'd hop on my soapbox for all the Washington people on the line and be like, I think I said this last year, kind of like regulation and rules to some degree drive behavior, and your participants in the market are going to look at rules and change behavior to solve for outcome. So I always focus on, are your policy decisions well aligned with what you want to see? And the example I would use here is we see all these subcap arrangements in the primary care space where you see managed care companies essentially shifting the risk from managing parts of the patient population away from the Medicare Advantage entity and into primary care entities that are then managing patient populations. And they're effectively taking the risk for these patient populations in what would seem to be a more lightly regulated environment from a care delivery perspective and from a cost management perspective. So you are seeing you're seeing tremendous growth in the number of participants in this space. You're seeing tremendous growth in the number of lives that are kind of captured under these arrangements. Kind of to Anne's point, it's still a very small percentage of the total pie, but you're putting up 25, 35, 45% year-over-year growth rates projected to grow at that rate for the next handful of years. I think kind of piggybacking on what Anne said, the hospital organizations, given the consolidation in the hospital market tends to look different than the consolidation in the primary care market. So you've got different competitive dynamics. So to Anne's point, they're not incentivized to move off the fee schedule. They're not incentivized to kind of take risks because they're getting paid well under the fee schedule. But I would just caveat, we're kind of seeing different degrees of movement in different parts of the market. I'll kick it to Ricky.
So I'd say a few things. So first of all, we need to think about what the end market is, right? Because value-based clearly is a good solution, right? Ultimately for Medicare Advantage. And we see more full risk, right? Value-based in that market. Not necessarily, right? At least for now, the right solution for commercial. And when we think about sort of what type of arrangement we see, right? We see more full risk on the Medicare Advantage side, because there are incentives there to George's point. We see, participating in an upside arrangement on the commercial. So I think when we think about the market opportunity and the addressable market, we really have to think about it by end market. And that's part of it. But more than that, when we think about what the limiting factor, to me, value-based is kind of like similar to how people always talk about what are the big trends, right? Demographics are the big trends. Value-based is one of them. But providers, hospitals, health systems don't have the tools to take on risk. So I think that when you kind of like, what is it? It's kind of like you tie the horse to the carriage. We need to make sure that there are tools that can help providers and health system take risk and allow for it, right? And there's connectivity between all of them before we really get to that massive shift. And I know that later we're going to talk about digital and healthcare technology, but to me, that is kind of like where we have to think about what is happening in the space right now, because that is sort of the foundation for later on kind of like acceleration and kind of like these value-based payment models.
Yeah.
And Paul, if I could add one more point, Ricky makes a great point about healthcare in this country is not one market. Healthcare is thousands of markets based upon which region you're in, which competitive environment you're in, what your payer structure looks like, what your risk arrangement is. I mean, right, your big divisions are going to be geographic and then Medicare, Medicaid, and commercial. And like, again, when you basically multiply the three by the regions, you come up with hundreds, if not thousands of healthcare markets. in the United States. So the idea that like, why can't we fix the healthcare system, or why is the healthcare system broken? It's like, well, which healthcure system are you participating in? Which healthcare product are you participating in?
Yeah.
Question.
Good. Yeah, I'd like to move us to telehealth now. And just to open this, my sense of, we all know that we will clearly have, much more telehealth after the pandemic or during the endemic than we did beforehand. And it seems as though the federal policy for Medicare is reflected in the latest appropriations omnibus, is kind of moving cautiously, following the advice that MedPAC has been making to Congress of, doing more analysis, and rather than locking the program in for a long time to, kind of unlimited telehealth, really looking at, what types of services actually, have a positive impact and which parts are problematic. What's your sense of what the private insurers are doing as far as their coverage of telehealth going forward?
Hey, Ricky, I'll let you kick this one first.
Sure. So I mean, when we think about what the private insurance are doing, I mean, overall, clearly in the last 2.5 years, we've seen that telehealth insurance parity, and I think for over a year now, that question has been a very relevant question in terms of when are insurance going to scale back, and is a telehealth visit truly an equivalent for an in-person? I think that, and each payer that we speak with has different philosophy, right? There's some that want to scale back very quickly, and others that have different approaches. But to me, I always kind of like think about, let's follow the workflows of what is actually happening in the marketplace. And today, when, one area where we're being told that telehealth makes a lot of sense, right? Pre-op, post-op, kind of like full-op services. Today, when I go to a physician, and I pay that physician, if it's a fee-for-service model, the payment is for that procedure, right, for that operation. I actually don't pay for that first appointment, and I don't pay for the follow-up appointment. So to me, here's an example where telehealth is an add-on. It makes it easier, but you shouldn't really be paying for it, right? Because we wouldn't pay for it in kind of like an in-person environment end-to-end. So I do think that insurance have to be and will be very thoughtful on where parity matters and where it does not. So for example, behavioral health, there's clearly very, very acute issue of supply and demand. And it lends itself very well for telehealth. So that is where you're going to see parity. So even if we see headlines that say that maybe reimbursement is lower, we have to kind of like really peel that onion, because sometimes it makes sense and sometimes it's not different than how things have been done in the past.
And just to add, I actually think physicians will have a say. I do a quarterly survey of about 250 physicians. And when I ask that question, depending on the physician's specialty, I get very different answers. Where some will say it depends on the reimbursement, because obviously the reimbursement is elevated via the public health emergency. Some say I prefer to see the patients in person. It's not the same. So I think they'll have a big say on how they want to practice medicine, because ultimately the physician is the ones practicing the medicine. So it makes sense for some, like behavioral, definitely, especially in rural areas. So, I also think geography will play a part in this as well, because in some rural areas, there's a severe physician shortage. So, but I think their voice will matter as well.
Yeah, I think the only thing I would dovetail on here is, again, depending upon where you sit, it's like, even as a payer organization, are you seeing telemedicine either as a revenue opportunity or a cost center?
Yeah.
And if you own your own telemedicine capability, again, we kind of come back to this fragmented delivery system. If you're an ASO provider of services and you have an integrated telemedicine model and you can charge for it, you're going to steer patients in that direction. And if you're a risk-bearing provider, you're going to see it as something that hits your cost of goods sold, and you're basically you're going to want to contain costs against your medical costs, and you might discourage it. We are starting to see a little bit. There's been rumblings inside the federal government, Paul. I think you alluded to this. Like, will the federal government in Medicare fee-for-service pull back the easy access to telemedicine that's been granted during the pandemic? We are seeing some of those initiatives at the state level, worrying about in the Medicaid populations has access to telemedicine kind of been too readily available? And then I know Ian talked about behavior and behavioral, and we'll probably hop into this. It does become very disease state specific. And I'd say, in general, like in what I would call like regular way acuity care, like going to a telemedicine doctor as opposed to going to the ER or the primary care space, we're starting to see utilization there come down, not quite approaching pre-pandemic levels, but normalizing at a number under 10% of total visits.
Yeah, let me ask about payments. I guess, what we don't know is when the public health emergency is ended. Will the parity between payment for telehealth and bricks and mortar care, be over? Will telehealth be paid less? And are the private insurers thinking that they might follow whatever Medicare does, or do they have their own ideas as to how they're planning to proceed?
I guess I'll hop in first on this one, and I'll go. Again, I think it depends on. It kind of depends on where you fit on the food chain, and if telemedicine is a cost center for you, you are going to try to pay less. You think about the health plans that are trying to start virtual first care offerings or virtual first delivery models as it relates to benefit design, right? They're starting with virtual first because they're expecting it's going to be the easiest to access and the lowest cost. And then you'll work, I'd say, just like in benefit design in almost any other category, you're going to want to work through your lowest cost care delivery options before you work into your higher cost care delivery options. And then if you're a revenue generator, if you're using telemedicine as a revenue generator, you're going to try to preserve reimbursement around it. I think over the long term, it's hard to imagine that telemedicine reimbursement is going to remain at parity to in-person reimbursement.
I agree. I think it obviously depends, but I think it's unlikely it stays.
It's again, it's interesting, just going back to, I think that it will require study and analysis to take time, because there are areas where I think about it. You go to a physician visit to in office, there's a lot of code stacking that's happening, right? That means that the total cost of that visit might be meaningfully higher than the telehealth visit, despite the fact that you have kind of like reimbursement parity. So I do think that from the private insurer side, there's going to be a lot of sort of analysis until we get to kind of like the true answer. But I would say that, and it's again, if we think about this holistically, what is telehealth? And if we think about telehealth just like we think about in person, right? It's just another medium of providing care. Is it really that it should be reimbursed? Should it be a telehealth code, or should the reimbursement be more around what is that particular service? How does this particular service apply to sort of that other services that a patient is getting?
Okay. Any thoughts about how, integration between virtual only telehealth providers and bricks and mortar, providers that, people see in person some of the time, is that going to be a source of real fragmentation, or are they finding ways to share information, et cetera?
I mean, I can take it. So first of all, I think that the digital first, which you kind of like, I think referring to, because you're referring to digital first and sort of that integration between digital and in person. Digital first are basically narrow networks, right? I mean, you control the environment, you control the leakage. You can very easily refer to sort of kind of like that a specialist. So I do think that digital first actually is going to encourage. It is an integrated approach. It will mean that there's just kind of like more collaboration, more cooperation between. And I think that that's something that's it's here to stay, and it's going to be have an increasingly more important role. It's sort of step therapy also, in a sense, right? We talk a lot about step therapy on the drug side. This is what this is.
That's how I was thinking about it when I talked about it as part of the benefit stack, because I was thinking about it as a step edit or a prior author, however you wanted to think about that process.
Oh, thanks. Yeah, that's good. Let's turn to mental health care. And, we know that the pandemic has, really increased the need for mental health care. And, but there are a lot of shortages in both inpatient capacity and for mental health clinicians. So, how are the payers likely to handle this imbalance? They perceive the need for more mental health services. The services are short supply. And let me ask one other thing is that, as the ability to get mental health services through telehealth makes it more attractive, I think, for many patients, and thus they'll want to demand more. But is this going to even exacerbate the shortages? And, we start wondering about, well, who's going to get those services? Or on the other hand, are providers able to actually deliver more since they can do it from home?
Maybe I can start with this one. I think this is actually a very interesting topic because the Washington environment, there's just no consensus among obviously Democrats and Republicans. And there's so much consensus around increasing mental health parity. And I actually think there might be a standalone bill. If one bill gets through Congress this year, it could be a standalone mental health parity bill that really addresses the mental health parity law in 2007, because there's a lot of the view in Washington among Congress is that health insurance is not following that law. So I actually think that congressional action will force almost insurance companies to cover benefits more. Because mental health, it's especially when you get to the inpatient side, it's very managed by every payer besides Medicare. Commercial is overly managed Medicaid is overly managed. And it's an area that the government's looking at. And because of the shortage on both the nursing side and the physician side, I think telehealth has to play a big part of any type of legislation that goes through Congress. And it probably will include some increased telehealth benefits once that bill goes through. But I actually think that increased coverage will be dictated by Congress.
I would take a little bit of a big picture approach to this. And Anne, I'd be interested if you have, I don't know the numbers off the top of my head for the inpatient mental health component, but we've looked closely at the outpatient mental health component.
Yeah.
And what I would say is that, again, I completely agree with Anne where things are going on mental health parity. But what we see from a big picture perspective is that if you look at the healthcare dollar writ large, where dollars go in big slices, hospital payments, outpatient payments, labs, drugs, stuff like that, mental health is not a big slice of the dollar. It's a very, very small slice of the dollar. So there is lots of room for mental health to grow inside of the health dollar, I'd say, without changing the size of the pie, so to speak. So I think that we can kind of achieve the goals that Anne is talking to around parity and not necessarily moving the needle on what the macro healthcare costs are. And the good news, right, is you can increase access through telemedicine while you mix down on price per visit at the same time. So I think, Paul, I like to make we're all going nuts 2.5 years into the mental health, into the COVID crisis here. We probably all need a therapist. And the healthcare dollar writ large says there's money in the budget for each of us to see one. So I don't think access. I mean, I think the labor shortage in mental health care is the issue. I don't know that cost and its place in the budget is the issue from the work that we've done.
Yeah, well, let me push further about this labor shortage. About won't that be a big constraint, and what might be done longer term to alleviate that?
So, and I think that that's something that we talked about a couple of years ago when we had this discussion at the very early days of COVID, and that is, practicing medicine right across states. Was allowed for a brief period of time, then was pulled out. If you think about mental health, here's such a way, right, where you bring technology in sort of telehealth services, and you can solve for this supply demand issues that we're seeing. Training therapists across states, right? You have someone in California that is 3 hours behind, they can work with people on the East Coast. There are easy solutions that require tweaks, and that's where I see the opportunity. It's opportunity that's going to come out of need.
Ricky said it, using technology to better utilize capacity.
Yeah.
Great. Thank you very much. As far as the other digital technologies, as far as monitoring chronic conditions, hospital at home, are either of those going to be more significant going forward?
I mean, I can lead it on every payer organization trying to drive every inpatient care delivery opportunity that they see into a lower cost of care setting, ideally into the home, has been, I mean, that's a trend that's been going on I'd say for at least 20 years now, I guess, right? And where we're getting to now is just what level of acuity can you drive out of the inpatient setting and into the home just becomes the question. I feel like this is kind of Anne's bailiwick because she's the hospital analyst and I'm not the hospitals analyst. But I know coming at it from the payer angle that's what everybody wants to do. We could talk about United Healthcare announced another $4 billion acquisition the other week of a home care company. Again, just building the capacity now to be in a position to provide care delivery in the home for people.
And how are the hospitals thinking about this?
I mean, the hospital's goal is actually to get the patient out of the hospital because I don't know if you've been in a hospital lately, but the patients there are very sick or need to be in a hospital. And their goal is to get the patient out into a good setting. And sometimes it's the availability of a good setting, like inpatient rehab, for example. And you have to look at capacity utilization. Is a very high capacity utilization. So there's not enough supply for the demand, but home is very important. And it's ultimately where the patient wants to be, is where the family wants the patient to be, but they need the patient to come back not too soon because hospitals do not want the patient to be readmitted. Like that's a big thing for the government, readmission rates. So I think payers, hospitals, you saw HCA actually invested in its first home health business, a small regional one. Everyone's trying to increase their access to some type of home health or whether it's digital, some type of capability, because that is where the care is shifting if the acuity of the patient allows it. And again, with the aging of the population, I always joke that I've been in this business for 25 years and people were talking about the baby boomers 25 years ago, but they're actually here now. And we will have and people turning 72 are growing 5 to 6%. So that is going to be a big focus for, I would say, every single part of the healthcare system, whether it's provider, payer.
Okay, great. This might be a good time to turn to questions from the audience. And I've got some here. One is circling back to an earlier analyst comment. Can you please explain why value-based care is not a solution for the commercial healthcare market?
Can I hop in on this just because I did a call on this week with a benefits consultant?
Great. Okay.
And it just kind of cracked me up where the benefits consultant at one of the large benefits consulting firms is working with one of his self-insured employer clients, and like it's kind of the self-insured employer sponsor wants the provider to take more risk and put more skin in the game, but they don't want to buy risk and they don't want to pay a premium to the insurance company. I guess I feel like there's, simplistically speaking, when you ask someone to take risk, you are asking them to commit some type of capital, which they then charge you a premium for, which nobody seems to want to buy or pay for. So why are we not seeing more initiative on kind of commercial plans moving towards risk, right? The hospitals that Ann covers are getting paid very well right now without taking risk. And these self-insured employer sponsors think that they're paying very low benefits costs without paying risk. And the insurance companies are being paid nicely to sit in the middle from an ASO perspective and adjudicate claims and, leverage their network contracts and leverage their discounts and leverage their rebates while not taking any risk. So everybody feels like they're doing great right now without taking for a bunch of risk and without paying for a bunch of risk. But everybody else wants everybody wants somebody else to put more risk in the game without paying for it. So we kind of, we're stuck with this circle of people who want, Paul, I want you to take all the risk for this presentation going well, without me preparing for it. Like, so it's kind of, you kind of walk into this. Everybody's got to kick in their share for value-based care to take off in the commercial space.
Yeah, that's a really interesting insight. I'm glad you brought that forward.
Can I add one point to that? I would
Sure.
say also in the commercial market, we're in a very tight labor market. And when it comes to those value-based arrangements, you would have narrower networks. Employees wouldn't have as much access as they probably would want. And health insurance is very important to offer employees. So I think the tight labor market is probably impacting that as well, from an employer desire to do it.
Yeah, and I would say one other thing when you think about commercial, we have to think about the population, how sick the population is, right? Value-based work when you are treating individuals that are sick, right? That have chronic diseases. Medicare population, Medicare Advantage, right? People over the age of 65. That is sort of the near term, right, market opportunity. You talk with MA markets and they said, even with that population, right, it's basically 20% of the members. It's about stratifying and identifying 20% of the members that account for 80% of the medical costs and managing them under value-based arrangement. On the commercial side, you just have less of that. So I think the dollar opportunity is smaller, and that's why in the totem pole, we're so early in penetration, they're just kind of like markets that present a bigger opportunity.
And Ricky, you make such a great part on Medicare Advantage, because when you look at Medicare Advantage versus almost every other market, like because of Medicare Advantage, through the regulatory process of the government, you have this broadly developed risk framework that does not exist in any other market, so to speak. So like the framework for how risk gets attributed and paid for exists in MA in a way that it doesn't exist in other places. And Paul, I like to drop in one of my euphemisms here, is that, you have to remember that we're always solving for three things. We're solving for, high quality of care, low cost, and broad access. I tell people you get to pick two. And the third one is kind of something that falls out of picking which tree you choose to prioritize.
Yeah, good. I've got a question here that came in before we started, but it looks really good to me. Why is Wall Street convinced that startups can manage primary care and save money? Are they right?
Oh man.
So I think that it's an interesting question, right? Because if you think about what are those startups, right? They're just kind of like we're seeing a lot of kind of like capital investment formation in order to develop sort of new models that can help, right? Solutions to close gap in care. And that is what these startups are about. So to me, it's less about, or can they ultimately some of them might ultimately become bigger organizations. Some of them might be part of already large organization, but it's about innovation. It's about where those startups, George talked about taking risk, right? Those startups can take on risk in order to help solve these gaps in care. And that's a purpose, just like in tech world, right? We're seeing tech startups taking risk and coming with innovating products. That's what we're seeing in healthcare.
Yes, I guess a lot comes down to, will they be effective at changing how primary care physicians behave? Or is it just a matter of providing primary care physicians with the right supports? And this will cause them to behave very differently.
I think you need to experiment at the margins. Like, you need to test and experiment at the margins. And one of the interesting things about primary care, and I'd say about healthcare delivery in general in this country from the provider perspective, is there's kind of no uniform handbook around that either. It's like, I'm here in Cambridge, Massachusetts, and the doctor coming out of Harvard Medical School right now learned how to practice medicine from the doctor who trained him, who learned from the doctor who trained him, which might be slightly different from the doctor who's coming out of NYU, close to where Ricky is, or there are variances in care delivery that result from how doctors were trained and how medicine is delivered in regions And I'd say you should think of that, like, again, I come back to like this fragmentation of the healthcare system. Like, we have these variances and nuances that exist everywhere. But I think what's important is that you continue to test and experiment around the margin. So, these startups, like, they're going to try new models, new incentives, new procedures, that try to create some new opportunities and some savings here.
And I would say, the dirty secret of healthcare, right? Healthcare, we always talk about healthcare innovation, but not a very innovative industry, right? And it's because it's a very regulated industry. It takes years to make changes. You need these type of innovators to drive the industry forward.
Good, thank you. This is probably a good time to wrap up our questions and take a break, and then come back on other topics. So I don't know, we're scheduled for 5 minutes or 10 minutes.
You're driving the bus, Paul.
Excuse me?
You're driving the bus.
Okay, yeah, let's do a 7-minute break. And I guess we'll just turn off our videos if we want, and keep everything open. I apologize. Someone reminded me that we don't take breaks. If anyone needs a break, they can step away, but why don't we continue the conversation? And I apologize to the audience watching as well as the analysts. So next, I'd like to talk about workforce issues. And, workforce shortages, especially for nurses in hospitals, obviously everyone's concerned about that. And maybe you could start, Anne, about, what are hospitals' plans going forward to address the nursing shortage they're experiencing now and expect to continue, I gather.
Sure. I think hospitals hope that some of it naturally ease, because what's happening during COVID is obviously we've had very elevated COVID hospitalizations, and they've had to recruit other nurses. So they had to use a lot of temporary per diem nurses when they had elevated COVID cases. They had to do a lot of travel nurses, which are 13-week contracts on much higher pay. So now that hospitalizations are decreasing, they do hope there's just some ease in that nursing costs going forward. But there probably is some structural change. It's similar to teachers. There's like this great retirement of teachers, because the average age of a teacher in the US, I believe, is over 50, and that is similar to the US. So there are nurses retiring, but I don't think it's 20% of nurses, but it's enough that causes some of the hospital companies that I cover to be concerned. And I think what they're doing initially this year is realizing and appreciating that these nurses are burnt out. So they'll probably get more bonuses, more vacation, maybe less hours per week when the COVID demand ends, and really doing what they usually don't do, and giving them a lot of love and tenderness, like things that they need to recoup and resolve the burnout. I know that sounds silly, but that's what they're doing. But going forward, in a hospital situation, and it depends on the state, you might have staff regulations, or there's industry accepted nurse staffing ratios. It will be an issue if there is some type of structural shift going forward. So I think permanently pay will be increased, increased benefits, pay for education. You just really have to want that nurse to work at your hospital. So even though it was always competitive to find a nurse, it will be more competitive. I know the US government is doing some things to attract nurses from outside the company. So there's some visas happening this summer so they can do some international nurses. But again, it is an issue. Hopefully it's not going to be an issue as we fear once the whole COVID hospitalization fixes itself. I think we'll really see how bad it is. It's probably not as bad as people think, but it will be an elevated pressure point going forward. And for hospitals, they can pay more. So I'm actually more concerned about the non-hospital providers, home health, behavioral, for example, because they may a behavioral nurse might make like $85,000 a year, but hospitals could be paying $120,000 a year. So they might leave a setting and shift to an acute care setting. You know, for a hospital, it's a margin impact, but for home health and behavioral, it's actually a revenue impact and a margin impact. Because if you don't have the nurses, you can't admit patients. So I'm more worried about just the non-hospital assets more than anything.
Oh, that's interesting. And I guess, the big question, which we can't know the answer to, is, a few years out, past the pandemic, is there going to be some structural change in people's willingness to become a nurse? Particularly in a hospital, because of what nurses went through during, the intense COVID time. And, I'm sure that it'd be a long time before we can answer that question.
Yeah, I think time will tell.
So I'll take a different approach to it. I mean, clearly we're seeing nurse shortages, and clearly there is this fatigue, right, of being in healthcare. But what we've also seen over the last couple of years, we've seen greater acceptance for a bigger role for nurse practitioners, right? For physician assistants, I mean, for pharmacists. So I think that it would be actually very interesting to see how the industry evolves, because if now you're being empowered and you can do more, and I think there are 23 states where allowed for that, does this mean that actually we are making this into a more interesting field, and we potentially could see new people kind of like coming into it? So again, it's going to take time, it's long, but I think that we also need to think about what the role is and how the role is evolving and is going to change.
I'll say I'm listening to the question, Paul, in my head is in a completely different place, thinking about like, have all the managed care companies appropriately priced for medical cost inflation for calendar 22, and what are the numbers going to look like for calendar 23? Because when we think about the labor shortage, I think we think about healthcare as a generally better educated part of the workforce and a generally more expensive part of the workforce. Having said that, with inflation at 8.5%, running at 8.5%, almost 9%, people who are not getting wage increases that match that are seeing their purchasing power increase. Historically, you have seen healthcare costs appreciate faster than inflation as opposed to slower than inflation. So at some point, do we have a healthcare cost catch up that we need to be concerned about? Is that a back half of it's probably, and because healthcare tends to run on an annual basis, probably looking like a calendar 23 event as opposed to a calendar 22 event. I'm seeing great recession. I'm seeing inflation. I'm seeing ballooning healthcare costs.
Yeah, I'm glad you brought that up, particularly because my Brookings colleague, Matt Fiedler, has recently published something about, explaining why the healthcare pricing numbers have been increasing so slowly, and that that a lot of that is temporary, and there's even the possibility of some kind of bounce back as a result of that, because so much has been really based on projections, certainly in Medicare, and the projections obviously were not accurate, and it could mean that the next projections err on the high side, say.
And it's also interesting, right? Because at least from a Wall Street perspective, the investment community was really favorably surprised by the MA rate increases, that they were so high and there was expectation below. What are they really based on? They're based on sort of these projections that we're going to see medical spend going up, and there is inflation, and if you have to raise it, not necessarily because you are giving the MA players just kind of like more dollars, it's because these are dollars that have to be used to offset this increased spend and increased cost and inflation.
Yeah, and I'd say, and that's, I'm going to start the jab. I'll jab at Ricky in here and say that's kind of a sticky wicket though, because from an individual company perspective, like we're talking about this this creative destructive cycle of new entrants that come to market and industry consolidation that occurs that gets rid of some of the new entrants or gobbles up some of the new entrants and creates stable competitive environments for the remaining companies that participate in the environment. I think while the rate increase is a great thing for the companies that participate in the space, as somebody looking at individual companies, I question that, you know, we've helped subsidize some of the inflation that we expect, but we're subsidizing marginal competition in the market with these great rate increases. And I like to look at the corollaries through the history of the space where you had just what tends to happen is that in spaces where there's rapid growth or where there's, rapid growth in an industry, and the rapid growth of capital towards an industry creates excess competition, which forces companies to not be lean and disciplined and kind of forces an irrational competitive environment to some degree, which then needs to shake out later. I wonder if we're doing that in the Medicare Advantage space where we're just, these great rate increases are subsidizing marginal competitors who might not be able to survive X an 8.5 or 9% rate increase.
Yeah. And actually, just while we're on that topic, do you see, continued entry into the Medicare Advantage space, or is that? I know some of the recent entrants have run into some problems.
I mean, we'll wait to see, kind of the next go around of the number of approved plans, but we continue to see, growth in the number of plans and the number of products in the space. Yeah.
Okay, thanks. Let me raise a question about long-term care facilities. And, we know the huge impact of COVID on nursing homes. And, will there be a long-term impact of, institutional long-term care providers playing a smaller role in the system relating to, various things of services at home for those that need long-term care services?
I could take that. I mean, I think longer term, if you're discharged from a hospital and you need rehabilitation, you can get it in a couple of places. You can get it at a home, which a nursing home might be the person's home, or you could get it at an inpatient rehab facility or home health. It really depends on the acuity of the patient. I do think after COVID, more people will probably be hesitant going into like a SNF or a nursing home environment to get rehab. So maybe they choose to go into an inpatient rehab hospital, which really, if you look at the government data, they have very good statistics. Like the readmission rates from an inpatient rehab back into our acute care system is only about around 7 to 8%, versus if you get care at a nursing home, it's more like 15 to 18%. So that's a big divergence in readmission rates. So again, I think there will always be the drive to take people out of nursing homes, but some families don't have the option. So I mean, I think nursing homes will always be around, I think over the next decade, just this focus on home health and improving things and offering more services in the home setting, which will alleviate the family, what the family has to do to help the patient. You'll see more shift back to the home. But again, I think it's investment into a lot of services, a lot of capability by both providers and the commercial payers for the ability to do that. But I was reading your question, like none of the hospitals ever talk about wanting to own a nursing home or get back into that business.
Okay, I'm glad you answered that next question. Let's talk about the future of independent physician practice. And, we know physicians are leaving independent practices. And what have been the most important destinations? I gather there are three. There's, larger independent groups, private equity ownership, hospital ownership, or insurer ownership. And, any perceptions on which types of ownership might, prove to be most viable?
I mean, when I look at what type of physicians, private equity or these private equity-based companies, they tend to focus on emergency room physicians. They tend to focus on anesthesiologists. They tend to focus on I can't, maybe neurology a little bit, but I actually think it really depends on the facility. Like for cardiologists, they tend to like to be owned by hospitals. And again, when a physician decides we want to not be alone anymore, there's also other factors that might determine that, whether their medical malpractice is very high. So like, for example, emergency room doctors' medical malpractice is very high. It's very difficult for them to be independent. Obstetricians was the third one that is a big, either hospital owned or publicly traded hospital owned. They tend to go into that type because of the medical malpractice insurance. Anesthesiologists, there was a big trend over the past, say, 5 years for them to really go into not own ownership anymore. A lot of that had to do with the reporting data. They just didn't have the money. They would have had to invest a lot of dollars into technology to report data back to the government, and they just didn't have the money. And that really led anesthesiologists giving up ownership of their practices. So again, I really think it depends on the environment, the type of things like that.
I think it's also a matter, I mean, at the end of the day, right, private equity is buying those not to own them forever. So ultimately where they're going, right? And I think that it all ties back to where we were before. Insurer ownership. If you have a large Medicare Advantage book, right, you want to own a provider, and you want to own a provider because that's going to create that stickiness with the membership, which is going to be increasingly important as the market becomes more competitive, and is ultimately growth in MA is going to slow down at some point. Same with hospitals, right? We talk about kind of like the move from the four walls of the hospitals more into the home. To stay relevant, right? Do you need to own these groups? So I think that the end game is that private equity does sell those to the
To
health
insurance,
plan and
yes.
to insurance and into health systems.
I think they covered it.
Good, very good. With the No Surprises Act having been enacted and implemented, and private equity owning the specialties of emergency medicine and anesthesiology where surprise billing was so important. Do you think this really undercuts the rationale for private equity to own those specialties, or are there enough other reasons, like when Anne mentioned the malpractice insurance, that it'll still be a significant thing for private equity?
It probably decreases their urge to buy it, because that was a big strategy. And not all private equities would do this, but some would. They would acquire these physician practices and specifically make them out of network to get higher reimbursement. I would say that has stopped, though, over the past few years, obviously because of the government's initiatives to stop, those type of things. So I would say yes, to a degree, but I would still continue. I don't think it ends it. I just think it probably slows the growth.
Okay, yeah. And also another reason that, the consolidation was part of a private equity strategy, and consolidation won't result in increases in fees so much because of the No Surprise Act.
Yeah, and also I think it depends on the specialty, like primary care. That's the hot thing right now. Several companies want to get into it, so you might see a big uptick in private equity based companies with PCPs and things like that. So I really think it depends on the specialist.
Okay, thanks. Actually, are there important insurers other than United Health Group through its Optum subsidiary and or Humana that are making large investments in physician practices today?
So,
Well,
Paul, the question, are there other insurers that are kind of pursuing that strategy?
Yeah, in a sense, what I was wondering is it that United is that Optum and Humana are kind of outliers. They're doing their own thing, but nobody else is doing that, or are others engaging in significant activity as well to own physician practices?
Yeah, so CVS under, I understand, in December, or actually a little bit before that, in early December, really talked about publicly through a press release about their intent to invest in primary care and to grow primary care. I would say again, because if we think about why United, because they have 25% MA market share. Why Humana? Although I don't think that Humana necessarily is really followed through on an ownership model that they're starting now. I think a little small and a little late, because they have 20% of MA market, right? And it's 70% of their business. CVS is the third largest MA player. So again, I go back to let's think about strategic investment they're making and think how they're tied to what markets they're serving. So I think that you will see that these investments for insurers that serves market where it makes sense to own. So do I necessarily think that Cigna should own primary care of ownership? No, right? Because they're not in the MA market. But so that's, it's kind of like it's follow the lines.
Yeah, that really makes sense to me.
Yeah,
Yeah, thanks for bringing that up.
And maybe
George?
just to dovetail on that, it also goes to, like, again, we're really talking about all this going on in MA and the focus being on MA because there's kind of there's the risk infrastructure there, and there's the ability to kind of shift costs and shift risk around and shift earnings around. And in segments of healthcare where that is less obvious, or you have a lower degree of capability to do that, it's just less attractive to do.
Yeah. Yes, I could see this also plays into the fact that we're likely to see a very different story for different specialties. You know, we've been talking about the story for primary care, and I think Ann mentioned that hospitals like to employ cardiologists in particular. And, you know, I could see how this market's sorting out according to the, you know, opportunities for different owners by specialty.
Yeah, I would say hospitals really don't like to own doctors. They will do it if they need to in specific markets, because once a doctor takes ownership, they tend to work a little less.
Yeah.
They do it out of need.
Good. Okay, let's talk about the insurance industry now. You know, which segments are seen as the most attractive for expansion at this point? Is it Medicare Advantage, Medicaid, individual market, or somewhere else?
Yeah, I mean, I think we'd all agree MA is clearly number
MA,
one.
yeah.
Yeah, MA is clearly number one. And then I think there might be some debate whether the individual market has increasingly sustainable attractiveness and is poised for growth off a very small base. Medicaid probably from a growth profile number two, except for we're going to go through this redeterminations period as we exit the public health emergency. It kind of resets the bar there, and then commercial just kind of lumbers along. Is that the consensus? Did I say anything anybody wants to disagree with?
It's the consensus, and I think that it's also important to kind of like just address the why, right? If you think about it, it is there just, first of all, it's a faster growing market with membership growth, and we are in an environment where price increases, rate increases are not necessarily a foregone conclusion. For now it is, but maybe not next year, maybe not the year before. So you really have to think about where the membership growth opportunity, and then there's also the predictability in the stickiness of that member. I mean, the exchange market, if you look at it, right, there's 25% turnover. When you're in the risk-taking business, 25% turnover means that you really don't know 25% of your population every year, and it's difficult to manage risk. And I think that's why people really gravitate towards that MA marketplace.
Yeah, the MA marketplace. I mean, not only is this very stable enrollment, but you could even invest in people's health since they're going to stay with your plan for many years.
Yeah.
Yeah. What about tech companies getting into the insurance industry? In a sense, are there real opportunities for them, or is it really just to, you know, establish a foothold and then get bought by an insurer?
Can the answer be TBD? To be determined. Right. I think if you were to ask the tech companies, they've got this shiny new bauble that is technology that they're going to apply to the insurance industry and do it different. And if you talk to older line insurance companies, they would tell you that the blocking and tackling and dealing with the regulatory industry of the US insurance market is hard work, and there's real value in the long-term understanding and execution of those businesses. Right now, and I put it like this. I say everybody's business in healthcare these days requires technology. You can't execute your business and operate your business without technology. That does not make every healthcare company a tech company. And understanding that bifurcation, I think, is important. And just the idea that you're going to, right? You can be just because you're a tech company doesn't come along and mean that you have the ability to like rewrite the rules of how the U.S. healthcare system works or the insurance system works. And again, Ricky made the point earlier, like this is a market that is inherently resistant to change and inherently slow to change.
Yeah, good point. So, this could be an analog to the pharmaceutical industry where, the development of new drugs, shifted over time to, biotech startups, but, that didn't run into the rest of the pharma's business, which is, gaining regulatory approval and marketing drugs. So I wonder if it's really a matter of tech companies will come up, and if they have a tool that is very attractive to insurers, they will be bought. And then the next challenge will be, how effectively can an insurer integrate what they bought into their organization.
Yeah, and Paul, that analogy is right on. I mean, we actually used that same analogy in our 2022 Outlook, where we said if you think about sort of biotechs, right? Biotechs are innovators. They are coming up with the new drugs. The large pharma companies are making them into products that can be used in the marketplace. So I think that's an important differentiation, not just for the tech-enabled MCOs, right? For all the other innovators that we are seeing in the marketplace. I think where tech is going to play an extremely important role is kind of like, how do you use the data? Because traditional managed care companies, they have the data somewhere there, but they really haven't done anything with that data. And here you have companies that are very focused on that. So how do you stratify risk? How do you enable? Because to me, without that tech, how can we get really to value-based care and to risk taking? So they have an enormous role, both on the back end, which a lot of healthcare is focused, but also on the front end, right? On the digital, on how do you engage members. So I think their role is critical. It's important, and we're starting to hear kind of like the large guys talking about it, right? These are sort of kind of like buzzwords that they're kind of like using, and I think that ultimately they'll work together, because there's really no other way to move this market forward.
Yeah, I almost wonder if in a sense, maybe we shouldn't be looking that much at the tech companies appearing to try to enter the insurance business, but it may be an order of magnitude more as far as technology companies that are just, selling their services as suppliers to the mainstream insurance companies. And that's maybe how new technology enters the insurance industry.
Well, and to dovetail on what Ricky was saying, like it's using the data, and then like, are you using it on the front end or the back end, which has tremendous implications for outcomes and cost? Like, are you using the data to keep people healthier, to keep them out of the hospital, to better engage with them and get them more involved with their health and thinking more about their health before they wind up having an acute care event, as opposed to, then there's using it on the back end after the acute care event for outcomes management, for disease management. Just wanted to highlight the upstream and downstream implications of how you look at the data and how you use the data.
Oh, good. No, thank you. And actually, have insurers been making progress in using big data to constructively intervene in the the delivery process for the patients they identify?
I can take that one. It's not really evident. And I think where we really need big data is on specialty drugs, because specialty drugs are obviously huge cost, and there's no type of plan design or tier in specialty drugs because they don't have the data. And when I talk to consultants and when I ask them, they say employers just are not comfortable really tiering this, especially oncology drugs and things like that, until they have the data. And they've always said whatever PBM comes up with that first will be the key winner, and we just haven't seen it. So I obviously data is important, but I think where I look at is what is the biggest cost right now, especially drugs, we don't have it for that specific thing. Other things we do, but that's the one thing that stands out to me that's missing when it comes to data.
You know, to me, data, we talked before about behavioral health, right? How do you take that behavioral health data, right? And how do you use that to understand which patient is more or less likely to utilize the drugs or to be compliant with certain, treatments. So again, I do think that it is going to be increasingly important. I do think that some of the tech startups, like for example, Alignment is starting to show some evidence, right, at how kind of like the data that they have is starting to have an impact on MLR. Still early days, but we're starting to see some sort of hints of proof points.
My last point that I add is so much of healthcare data is unstructured data. Mm-hmm. How do you use it? How do you take the unstructured data and turn it into something that's quantifiable and structurable and that you can employ into care delivery? It's hard. It's very hard.
Yeah, I guess that's why it's been slow to make that useful. Let's change topics again. Social determinants of health and equity. And are insurers or large self-insured employers taking concrete steps to address social determinants of health and racial and ethnic disparities in access to care?
So, this is probably the biggest, right? And more social determinants of healthcare and health and equity with behavioral health, I think are really kind of like the two biggest issues that have emerged out of the pandemic. I think interestingly, there was a question before about sort of those primary care model and innovators. We're seeing some of these primary care value-based models that are concentrated right around kind of like areas with certain populations where they help kind of like close these gap in cares and help population that in the past have been marginalized to get the care that they need. We are also starting to see some plans, and again, these are more sort of the startups that are looking at plan design, right, and different plans that are more focused on ethnic groups because there are different needs. So very early days, but we're starting to see more of it. And I think that, again, when we think about what are the longer term trends post-pandemic, I think that's a very important one.
Great. Okay. Medicaid managed care. How are the various state demonstrations that have relied on private plans to serve beneficiaries dually eligible for Medicare and Medicaid working out? Has anyone, been following that?
I'll say I have not followed it as closely as I should. I know it's a very high pressure point because they are your hardest to treat, most expensive, and kind of least that's your hardest to treat, most expensive, and least responsive patient population. So and I feel like as long as I've been looking at managed care, the idea of getting to the duals has been a challenge. I kind of like what Ann said on PBMs. I don't think anybody's cracked the code yet, given the nature of what the dual eligible population looks like. But
yeah,
and clearly, it's a large opportunity. I think there are like 12 million duals, maybe 3 million are managed opportunities there. But one thing that we have to remember when we're asking, are there proof points, is what the MMP program started in 2013. It takes time for these things to keep momentum, and then COVID happened. And that kind of like put a stop to everything. And so I do think that has put us, we're now at the third year, that has put us at least 2 to 3 years behind in really kind of like understanding what's the impact and moving forward. And I think that's true not just for this, but for a lot of other demo programs, a lot of other projects that, whether it's CMS, CMI, have been kind of like looking at.
Good, thank you. Question about PBMs. It seems though, over a bunch of years, most of the major PBMs have been acquired by insurers. Any perspectives on how the vertical integration between PBMs and insurers has progressed? Has this turned out to be valuable or not?
I can take a shot. I think it actually depends on the company. Like, for example, CVS was the first one to do it, over 10 years ago. And I do believe that they've gained market share because of their vertical integration into the PBM and now the health insurance. Because if you look at Walgreens, you look at CVS, you take out all the COVID noise, Walgreens scripts are flat-ish, where CVS is still growing mid-single digits. And that to me is evidence of their strategy to acquire payers and move market share and shift them to the retail setting. So I would say for CVS, definitely yes. I'm less skeptical right now of Cigna and UNH. It doesn't hurt them, but has it benefited them like they have for CVS? I would argue not as much.
So I would say, CVS has been at it the longest, right? They've kind of like owned Caremark for a very long time. The others, this is more recent. But if you really think about where it makes sense, where it adds value, and makes sense in specialty.
Yeah.
Specialty management, right? That is where the cost is on the medical side. And I think that if you think about what kind of like United talked about in their analyst day, right? They want to be in the PBM side in Optum Rx in the area of where they add value, not where they act as a claim processor or transactional.
Yeah.
And that's where the tie with the insurance is. And I think that we're actually going to start to see more impact to the bottom line in 23 and 24, because that's when we're going to see the Humira biosimilar introduction, we're going to see a bioequivalent, and all of a sudden these PBMs, aside from just being a PBM, they have another function, right? Especially pharmacies. And I think that probably 12 to 18 months from now is going to be the first time we're actually going to see meaningful impact to operating income, to growth rates. And then longer term, it's how well are you integrating really kind of like managing the medical with managing the specialty. How do you use big data to do it? How do you use technology, right? It all comes together.
Yeah. Since only the largest insurers are integrated with PBMs now, what are the implications for the other insurers? Is this going to, in a sense, put them at a significant disadvantage and kind of lead to further consolidation in the insurance market?
I guess I'd hop in here and I'd say, I think if PBM, most people, I think if you spoke to most people who aren't on this call and aren't listening, they wouldn't know who their PBM is or what a PBM does. And PBM generally is a business that operates in the back office of healthcare, and it's a business that benefits from obfuscation. It's kind of a business that benefits from being in the dark. I think that you've seen Anthem effectively build its own PBM. Centene has been public about wanting to, rework to some degree its PBM partnership, whether it stays with CVS or whether it picks a new partner. I guess what I've been looking at most recently as it relates to PBM is there were a lot of state legislative initiatives that could have negative regulatory impacts on the PBMs. You're not necessarily seeing anything at the federal level, but there are about 15 to 25 states that want to drive increasing transparency into the PBM space, change the pricing models, change the reimbursement models, turn some of the PBMs into a fiduciary. So I guess I think that PBM historically is a business that has benefited from scale, and you've seen consolidation into 3 large PBMs, which have found homes inside of 3 large insurance companies. And the only way it seems to dislodge that scale or reverse that scale, and I kind of say this from the perspective of whenever normally functioning markets seem to get out of balance a little bit. Sometimes there's a regulatory course correct, and are we seeing the beginnings of a regulatory course correct at the state level? That's so I think it's been a benefit to the MCOs. I think it's been a benefit to the PBMs. I think there are industries that are concerned that there needs to be a course correction that has to occur at the regulatory level, particularly at the state level. Particularly, I'm talking about those, state boards of pharmacy and state pharmacy lobbies that are trying to push this. That I guess, while I think there's been a big opportunity and big benefit to the MCOs, I worry that competitive balance may have gotten a little bit out of whack. And I'm seeing risk in that market as opposed to seeing tremendous opportunity in that market.
I see. Thank you. Our time is running out. Let me just get to a question from the audience as we finish up. Given the evidence emerging about interference from outside investors in clinical decision-making in primary care and other physician practices or hospitals, do you anticipate greater regulation affecting the role of management services organizations or related structures?
I don't know that I agree with the premise, Paul.
Yeah.
Okay, that should be the take home for the audience.
Yeah.
Yeah, I think we're, let me wrap this up now because I want to thank you because I think each of you have done a magnificent job today in contributing to this discussion. I think it's been really rich. I hope our audience feels that way too. I want to thank Arnold Ventures again for providing support for this event and thank the audience for staying so long. So I guess we'll end it right now. 1 minute early.
Till next year.
Till next year. Yes.